different day speaking about the topic of management of retreatment difficulties. So I think most of us are familiar with this kind of radiograph, seeing these periapical radiolucences below roots of ill-treated or poorly treated tooth. And after good treatment, we can notice the absence of radiolucency. So we can notice the difference between the failure and the success. So we have some clinical signs and radiographic interpretation to know how is the case, our case are failed. Maybe if the patient having symptoms, pain, swelling, sinus tract, we can identify that we have failure. And from radiograph, if we can see radiolucency, which is increasing in size, we know that this is a failure. So we know success and failure, but according to American Association of Endodontists, they make it more or better described, giving healing, healed, or failure, or questionable. This is what we can find in after endodontic treatment. Either the case is healed, means we have normal radiographic signs, or failure or diseased, mean we have a radiolucency which is increasing in size, or that not go after good treatment, or in healing status. That means we have a periapical radiolucency that's decreasing in size, but it's still present. So we can't call this case as healed. It is an healing process. And for questionable cases, the cases with periapical radiolucencies that we don't have any change in size for a long time. So we should wait for maybe 1 year, in some literature, 2 or 4 years, giving more time for healing. And also it's like a clinical judgment situation. You know, you can see good treatment and you have lesion, you need to give more time for healing. Like in this case, this patient came to me, asked for crown or coronal coverage for these root canal treated teeth. What I saw is we have a periapical lesion, but also we have a well-treated or a good quality endodontic treatment. So what to do? What should we consider this case? Is the failure? Is the failure? Should we go and process the coronal coverage? What do you think? Okay, actually with this kind of treatment, we don't know how was the situation or the previous situation before this treatment. So we need to ask the patient, how long did you have this treatment? And I asked the patient and is telling it's 4 months. Only 4 months back, he had this treatment. Okay, so maybe the size of lesion was bigger than this, and today he's in healing process. So I need to give another appointment, maybe after 3 months, just to follow up. Today, I'm having a reference for what I'm having. So I'm giving after 3 months, we're giving follow-up to compare, is the healing process or is it a failure? And this is a patient, after 6 months, he's coming with mostly complete healing. So that was a healing process, or it was a healing process, not diseased or failed treatment. And this should be considered only for cases which is well treated. So if the patient came to me with this kind of lesion with poor treatment, for sure I'm not giving follow-up, I'm doing retreatment, right? So now in this case was a healing process, so giving another appointment for follow-up and comparing between the radiograph today and radiograph we took 4 months back or 6 months back. We'll also refer many reasons for failure: inability to reach to the working lens, inability to clean well the whole root canal system, presence of obstacles inside the root. You'll not be able to manage the complexity of the root canal system. So ledge, broken files, all these errors will lead to failure. And we have the usual suspects, which is the microorganism. We call it the usual suspect. Microorganism present in the root will cause failure. We're calling biological failure. It's because of presence of microorganism. This is the common having biological failure in poorly treated teeth. But what do you think about this kind of treatment? This is a premolar, Medora premolar. I treated long time ago. It's for a friend. I think RCT is good. Root canal treatment is good. Patient left, and after 3 years, he came to me complaining of pain. This is a tooth, and he's complaining of pain. What do you think? Should I do retreatment? Should I do retreatment for my work? I can't see periapical lesion, but what I'm having here is a perilateral radiolucency. So my concern here is that might be a vertical root fracture or a crack that extending to the root. So this should be my mindset. Reason for failure. It's not about I have a failed case, so go for retreatment. No, we need first to identify the reason for failure. So if you look to this tooth, it's already treated 3 years back and no coronal coverage. And if you can see, tooth already in malocclusion. So vertical fractures or coronal cracks into the root was highly expected. I told them this tooth mostly have a vertical root fracture, and he agreed to extract. And this is the tooth after extraction. We can see here we have coronal crack extended to the root. For sure, if you decide to do retreatment for that tooth without good diagnosis, you still have failure. So it's very important to identify the reason. We're calling this kind of failure as a mechanical failure, not biological. This is failure in function. And here we need to differentiate between two things. Coronal cracks extended to the root and vertical root fracture. Commonly, we're calling vertical root fracture, but we should understand well that vertical root fracture starting from the apex, extending to the crown, or starting in the root. However, for cracks, coronal cracks, start in the crown and extending to the root. So the last case we saw is already coronal crack extended to the root. Okay, and it's highly anticipated in case of retreatment or in case of failure. 11 to 20% of cases of failure are due to mechanical failure. So it should be kept in mind that the well-treated tooth could be failed treatment. We have with failed treatment could be a vertical root fracture or mechanical failure that need to be extracted. Cases like this, if you look here to this radiograph, you can find separated file as the apex. You can a little bit poorly treated endodontic body treatment for this molar. So many of you, I think, would think to do retreatment. The other tooth, it's a good quality treatment also in CBCT. But see teeth after extraction, this is the teeth. So you should consider in 11 to 20% of failed root canal treated teeth that we might have a vertical fracture. So this could be a contraindication. This is very important because I used to have this question, doctor, I did good endodontic treatment and patient is still in pain. I really evaluate his work, it's too good, reaching to working length, good cleaning, good disinfection, still patient in pain. So we might have this kind of failure, which is a mechanical failure. That's why it is very important to evaluate treatment when only tooth in function. Because I know some dentists after endodontic treatment just do occlusal relief or occlusal reduction. So tooth is not in contact and patient left and he is happy because no pressure in the tooth. Can you imagine one day if this tooth have now, we do good coronal coverage or crown, now tooth in function, might be after being in function, these signs of failure will appear. So it's very important to evaluate your treatment only if the tooth under function or in function. So some points about retreatment prognosis. Actually, we know how that if the tooth or root canal treated tooth have periapical lesion, success rate will be lower than if there is no periapical lesion. This is very important. Also, if the size of lesion is big, success rate also will be lower because we have good prognosis if the size of lesion is small. But for prognosis, actually, I like this article. It's already made by our founder of our group, Fabio Gorni, speaking about prognosis evaluation according to type of error or according to type of reason of failure. So we have some reasons of failure like instrument separation, also like perforation. Those are reasons for failure. But for prognosis, they are not the same. Because actually, if I have separated file and I'm able to remove and reshape the canal, so no alteration in the root canal anatomy. But with perforation, already anatomy is altered. So if I have cases like calcification or apical stop, broken instrument, underfilled canals, like in these cases, actually we have a good prognosis. First case, as you can see, we have short obturation. Just remove it, reach working length, you maintain shape of the canal, no alteration, so prognosis is good. Same for a broken file or separated files that you're able to remove. Now, still we have a good prognosis. But on the opposite side, if you have errors or reason for failure that altered the root canal anatomy, like perforation or stripping or internal absorption, already prognosis is lowered, because in these cases we have alteration to the anatomy. Like in this case, here we have perforation. We already can manage the perforation using MTA or putty pipe ceramics, but still prognosis is lower than in case of no alteration to root canal anatomy. So we should understand this and know the prognosis of our case before starting our treatment, so we can manage discussion with the patient about the prognosis. Don't give promises to the patient in cases like this, because already we don't have high percentage of good prognosis. I'll speak a little bit about managing missed anatomy in case of retreatment for management of perforations and apical transportation, but we need to know that prevention is better than cure. So as I'm included in many training universities, I always get this question from dentists. Please, doctor, we want to learn how to manage separate instruments, how to do bypass, how to do retrieval. Can I ask all of you, have you ever broke a file? Sure, are breaking files. A little who will say no, and who will say no mostly didn't do more more cases of root canal treatment. So you're working, you will have a fracture. But the problem is, if you have this kind of fracture or separation, imagine you're doing 3 root canal treatment for a patient, and in each tooth you're separating a file. You're doing root canal treatment for a molar like this, and in each canal you're separating a file. So you don't need to learn how to manage separate instruments. You need to learn how to prevent instrument separation before learning how to manage, right? So you need to identify your goal. When we announce that we are doing a course for bypass and retrieval, it's fully booked in 2 days. When you announce, come and learn how to prevent instrument separation and the errors, I know how to use rotary instruments. I'm having endomotor files. I just need to know how to manage files after breakage. So it's very important to learn how to avoid errors before knowing how to manage the errors. In a case like this, this patient came to me and she has a strange request. She's telling, doctor, please, I don't want a file to be separated in my tooth. She didn't tell, doctor, please finish me quickly. I want to finish in a single visit. No, please, doctor, don't separate a file in my tooth. Okay, I lift my instrument and please speak. What's your problem? She's telling, every time I'm doing endodontic treatment, I have file separation, file breakage in my tooth. So I'm looking at her radiograph. This is a tooth in question, tooth number 3.6, and I can see here, yes, 3.7 already have a separate file, and in the second canal in mesial root, it's already short. Doctor was not able to reach to the working lens. What she's telling more, she's telling, doctor, imagine that in one time or one of my tooth, I did root canal treatment or I had root canal treatment, file separated, and the doctor need to do hemisection, remove the root. Yes, she's right. On the opposite side, the same tooth on the opposite side, we can see we have premolarization to tooth number 4.6. In this way, patient is doing self-assessment. She's telling me, doctor, my teeth are quite difficult. So please don't underestimate my tooth. That's very important. Listen to the patient very well to avoid errors. Okay, so I start my treatment doing regular steps for pre-flaring, enlarging coronal portion of the canals, just to have less contact between the files in the coronal portion, so avoid separation, also limit stresses on the file in the coronal portion. And it's very important step. Pre-flaring, already proved in literature that if you do pre-flaring, you avoid many errors like ledge, instrument separation, straightening to the canal. Before introducing my handy file to the forward-working lens, I'm first doing pre-flaring, enlarging the coronal portion of the canal. After enlarging the coronal portion of the canal, I can easily go to the apical third or the apical zone by manual files to do what's called glide path. Here, after pre-flaring and enlarging the coronal third, now I'll start doing my glide path preparation carefully, pre-curving the file, and use the watch wind motion. Watch wind motion, don't be in a hurry, because already teeth for this patient are difficult. So don't be in a hurry. Try to avoid error. Yes, watch wind motion, watch wind motion. Never force an instrument inside the canal. Reaching to the working lens or having established glide path is very important. I consider this the most important step in rotary instrumentation. Having glide path. What we mean by glide path? Canal is patent from orifice to the foramen. So if after having glide path, I had a ledge in the canal, simply I can bypass. If I have separated file, simply I can bypass, because already the path of the canal below this blockage is patent. But imagine having a ledge or separated file and still canal is not patent. You double the difficulty. Now case is more difficult. So better to avoid error than learning how to manage. Now I reach to the working lens. I did my obturation, that's the tooth. Now patient's happy and I'm happy. No errors, we maintain the shape, no transportation, no ledge, no file separation, and treatment, I think, is good. So this is very important to learn how to prevent errors or how to avoid errors that could happen during access cavity shaping obturation, rather than learning how to manage this kind of errors. Even if the case have multiple errors, still we can manage. In this case, I have a separate instrument in the mesobuccal root, and it is below the curve. I have perforation in the floor. I have missed canals. All these are errors. Or these are reasons for failure. But because I know how to manage each situation, I can continue my treatment. Yes, prognosis is lowered, but still the case is manageable. For the separated file, as is beyond the apex, I know that retrieval is not an option for me because I can't see the file. It's already beyond the apex. So bypass is the solution. I get bypass. For perforation, I know that I need to seal it with MTA. For missed anatomy, it's easy for me managing missed anatomy. It's already a distobuccal canal, not an MB2. So actually, it's easy. Using magnification and ultrasonic, I can manage. So whatever the errors in the tooth, as it is manageable, so we can continue our treatment, provide good quality treatment to our patient. What already proved in literature that the most reason for failure is uncleaned spaces or the missed anatomy. And if we're speaking about missed anatomy, we cannot ignore that MB2 is the most common missed anatomy, right? Or most known canal to be missed, the MB2. I just heard some clinicians who are saying MB2 is always there. Do you think MB2 is always there? It is not always there. It's present and it's high percentage. According to last prevalence, we have prevalence of MB2 ranging from 48% to 97%, with a global prevalence of 73%. So it is not there 100%, but it's already a high percentage. So I should take care, giving more time trying to locate or trying to search the floor using ultrasonic tips, mouse bears maybe, just to be precise in cutting or trying to locate the canal without too much destruction to the anatomy. Many cases we can find MB2, and we know the situation or the place of MB2 is a little bit mesial to a imaginary line between the mesiobuccal and the palatal canal. Sometimes it is so close to MB1, and sometimes it is far, far from MB1. We can notice MB2 in little cases, actually, little cases we can see that MB2 already exists, because most of the time we have superimposition of MB1 over MB2, but in case like this, I can easily understand why we have failure. Already I have a canal which is untreated. So already you can see it in the radiograph. Clear? You can see that we have missed anatomy. So now I can understand easily the reason for failure. Here, MB2 is clearly seen. In this case, MB2 is clearly seen. I can easily manage this situation. But we already know that it is have high prevalence. So even if I can't see it in the radiograph, I have to go and locate it using proper tools. But what's strange in this case, this patient came to me as a referred case. Doctor, I'm referring this case for you because I can't locate this buccal canal. It's maxillary molar, and the dentist can't locate this buccal canal. You can see that red dot. Actually, this is the site where the previous doctor were trying to locate the distal buccal canal. This is a common place or common site for distal buccal. But for me, this is not the place that I should try to locate distal buccal there, because I don't have any guide. I don't have an isthmus or floor map that's showing that I should try to locate distal buccal in that site. Looking more to the case, I can see that from palatal canal, I have a small isthmus extended towards the buccal side. You can see it here. Small isthmus. Yes, that could be a guide for me to use ultrasonic tips, trying to do a reduction and find the entrance of the canal. And yes, after doing reduction, this is the site of distal buccal canal. Strange, right? It is not the common site. That's why we need to adapt our knowledge to the anatomy, not the opposite. Don't adapt anatomy to your knowledge. Don't say DB2 should be here, so I will try to locate it that side. No, we have guides, we have rules to manage this kind of complication. This is not commonplace for distal buccal canal, but I know where to search, where to try to locate, because I already following rules or following guides. Floor map, isthmuses are good guides to locate this anatomy. And you can see here that we already have fused distal buccal and palatal root. Okay, now we have one mesiobuccal canal and fused distal buccal and palatal roots. Speaking about removing gutta-percha, I know that many of us who are dealing with retreatment cases can easily reach to the working lens and gutta-percha or gutta-percha still remaining on the wall. If you look to the second radiograph, I reached by my file to the working lens and the apex locator showing me that I reached to the full working lens, but still too much amount of gutta-percha inside the canal. We should pay attention to the remaining gutta-percha inside the canal. Should be completely removed. It not only acts as a barrier between contact of hypochlorite and contaminated dentine, but also it may hide anatomy. Look in this case. This is a premolar. Looks easy premolar. Poor treatment. I have a lesion. For me, when patient came to me, I said, okay, I will remove the gutta-percha, reach to working lens, good shaping, good irrigation, and easy case. Trying to remove gutta-percha, and as a microscopic user, I can see what's inside. Here I'm having piece of gutta-percha stuck to the wall. I tried using ultrasonics, using solvent to remove that piece of gutta-percha, and it's not coming out. It's stuck in a place. I said, okay, it's already coronal. I will continue my treatment to the working lens as a single canal. But you know, you're working with well-equipped in well-equipped clinic. How is this gutta-percha I was not able to remove? I will remove it. And I insist on removal. It takes time, maybe 20 minutes to just remove that piece of gutta-percha. I start to use ultrasonics to remove that piece of gutta-percha. And here was a surprise. Already that piece of gutta-percha was blocking canal entrance. So if I continue my treatment, treating only one canal, still I will deal with failure. So it's very important to remove all gutta-percha from the canal. It will not only act as a barrier between contact of hypochlorite and contaminated dentine, no, but also it might be blocking canal entrance. So you might end at the end with a failure. Okay. For gutta-percha removal, this is my protocol for manage all the gutta-percha inside the canal. For the coronal portion, I'm using ultrasonic, just ultrasonic tips. It will make softening to the coronal gutta-percha, followed by a larger taper file for the coronal and mid portion of the root. And for the apical third, I'm using less tapered files, followed by dynamic files. I'll show you how dynamic files working for removing gutta-percha now. This is the way I'm doing gutta-percha removal. Using ultrasonic, you know, we have heat generation from ultrasonic. Now it is softening the coronal portion of gutta-percha. So when I'm going after that, using rotary files, it will easily engage or easily penetrate the gutta-percha present in the root canal on the coronal portion. Easy, you can use ultrasonic to remove that coronal portion of the gutta-percha or softening this coronal portion of gutta-percha. After cutting, we just open the coolant to remove that portion we already cut from the coronal portion. Now I'll start to use larger tapered file to remove Gutta-percha from coronal and the middle third of the canal. For sure, the file will penetrate easy of Gutta-percha because it's already softened. A little bit picking motion inside. I don't like to use solvent. I rely most of the time on rotary files directly. With the larger taper file, I can manage the coronal and mid portion, mid Gutta-percha in the mid portion of the root. Same for the palatal canal. And you will see now that we already have cleaned canal, or what looks as a cleaned canal, but still we have Gutta-percha inside. That's why dynamic files for me is important in case of Gutta-percha removal. This is less tapered file for the apical portion of the Gutta-percha. Now I'm using dynamic files like XP Shaper, XP Finisher. These files with high speed, it will expand inside the canal, will touch more canal wall, and as you can see now, Gutta-percha still are coming from inside the canal. Thanks to adapting on root canal irregularity. Again, now it looks clean, still looks clean, and still it has Gutta-percha inside. These files are used on high speed, so it will expand. The pili of curvatures will expand, touching more canal anatomy. So this is my protocol for Gutta-percha removal. So consider this very important step during the treatment. It's not only reaching to the working lens, but you should remove all the B or all remnant of the old Gutta-percha inside the root canal from your old treatment or previous treatment. Okay, sometimes we might deal with uncommon anatomy. And we should identify this in many cases from pre-root radiograph. If you can look here, I have radiolucency besides the palatal root. Okay. Yes, we have radiolucency. And you can notice also we have like strange anatomy in that side. So before starting my treatment, I'm trying to look for extra anatomy. And actually that was easy. This is the case after I removed all the restoration. We can see that these are buccal canals. These are buccal canals. We have Gutta-percha inside. This is a palatal, and we have another palatal canal. You can see here, we already can see that we have pulp tissue in that canal. This is an instrument canal, which is responsible for the failure. So easily, I can remove the old Gutta-percha. It was a single cone, so using micro tweezer or micro forceps, you can easily manage this piece of Gutta-percha. And instead of removing by rotary files, you might have cut the master cone or remnant inside the canal. Simply, you can remove it using a micro tweezer. And this is the case after preparation, 2 buccal canals and 2 palatal canals. Already, I identified this from pre-root radiograph, and it was easy for me to detect after removing the old restoration. And here's the case after obturation. We can appreciate the presence of isthmus between the 2 palatal canal, which got filled by sealer, mostly sealer, because in this case, I used single cone with bioceramic sealer. Here, the palatal canal, I'm putting my bioceramic sealer in the mesio, the distal-palatal. Now, in mesio-palatal, and you can see that sealer already coming from the other canal. So we have connection thanks to 3D cleaning and 3D obturation using the bioceramic sealers and Gutta-percha. Now, using master cones to push sealer inside clean spaces, and this kind of treatment we can have with the patient. Okay. We all know that when we have a lesion in the furcation region, you have lesion in the furcation region, it might be because of perforation. Also, it might be because of periodontal disease. But when we have perforation or a lesion in the furcation region and tooth periodontally sound, and we don't have perforation in the floor, mostly we can anticipate a lateral canal going toward the furcation, which we are calling furcation canal. Yes, this is the way we can see this kind of canals. It's a furcation canal, which is responsible for the lesion present in the furcation. But let me share with you this case. Here I have floor or lesion below the floor in the Furcation area. So I was anticipated presence of lateral canal towards that side. I start to remove the metal post. I removed also the old Gutta-percha, and here what I notice, the Furcation canal emerging from the floor. Some might see this as a perforation, right? You might consider that a perforation or might be mid-mesial canal, but this is a normal anatomy because already I have dark line connecting between the main canals and that anatomy. And I am working using a microscope. It is not made by previous doctor. And for me, I'm clearly or precisely removing all the restoration and Gutta-percha. So this is normal. This is normal finding. Furcation canal, and it's very rare situation. But I'm considering because I already have lesion in the Furcation area. So I removed all Gutta-percha on the other canal. And at the end, I cleaned that canal, Furcation canal, which is coming from the floor using ultrasonics. For sure, I can do shaping in that small part, and I sealed using putty bioceramic material. So, as I said, we should adapt our knowledge to the anatomy. What about cases with lateral root perforations? I think this is a quite hard situation to manage perforation inside the root canal, but for me, the best technique to manage lateral root perforations is a sandwich technique. Sandwich technique means below the perforation level, we use a master cone and Gutta-percha to seal it. And as a perforation site, we just place MTA or putty bioceramics. And for the coronal portion, we need to use warm Gutta-percha, just the injection over the repair material. So this is the way we are doing the technique, just placing the master cone to a level below the perforation and using MTA carrier or putty bioceramic carrier, we just start to insert increments of MTA or root repair material in that part. This technique developed by Fabio Gorni in 2011. And for the coronal portion, after placing the root repair material, we just inject warm Gutta-percha to seal the coronal portion. Then we can apply our etch and bond and seal the cavity. Now we see a clinical case. Here we can see perforation in the mesial root, and I can understand the reason. I can understand the reason. Why is this happen? Because a dentist didn't do pre-flaring. He didn't enlarge the canal, so he has an off-center or not a straight line access to the mid portion of the canal, and it ends up by a perforation. So before management, I need to correct the error. I need to do the pre-flaring. So just I'm doing pre-flaring, I can have a straighter access to the apical portion of the canal. And this is what I did. Let's see how I repair this perforation. This is a mesial canals, mesiobuccal, mesiolingual, and you can clearly see the perforation. In that cases, I like to use also bioceramic sealers. So if some sealers came in perforation site, I don't have a problem. Here's a master cone. I use a modified hot technique. Mesiobuccal canal. Then using heat carrier and doing down packing to the master cone. Either you can use a heat-friendly bioceramic sealer or use it in modified hot technique. Now I'm doing down packing in the canal with perforation just below perforation level. So at the perforation level, I will use the putty bioceramic or MTA for repair. Now I'm doing compaction to the apical plug of Gutta-percha or the Gutta-percha to seal the apical portion of the canal. Pack filling using warm Gutta-percha. So I'll be having good adaptation to the material to root canal irregularities. Now compaction or pack filling the coronal third. This way, I finish the main mesobuccal canal. I start to remove the excess sealer using micro brush coated with distilled water, because we can remove bioceramic sealer using water. Now perforation site is ready to receive my repair material using putty bioceramic with the carrier. For the first increment, I'm doing gentle compaction using paper point. This is suitable plugger. Second increment was a putty bioceramic. And don't think to seal perforation using bioceramic sealer. This is wrong. Only putty bioceramic. This has different consistency to use for this kind of repair, right? Now, backfilling using a warm Gutta-percha. Compaction. This is a sandwich technique. For sure, this kind of management of errors in the mid portion or in the apical portion of the canal is quite tough if you don't have magnification, but it's still doable. But if you want to have a repeatable outcome or more predictable outcome, using magnification in these cases would be of great value. Okay, another case of retreatment with open apex. I don't know or can't understand this type of obturation. I think the dentist missed the main goal of our treatment. It's not about putting Gutta-percha only inside the canal. We need to do cleaning and disinfection and good seal after that. Actually, if you know the main goal of our treatment, your treatment will be very easy. Our focus during endodontic treatment should be always on the microorganism. From access cavity, look, from access cavity, we're trying to reach all the canals. Why? To reach to the all microorganism, right? After doing the access cavity, we need to reach to the full working length, not to be short 2 millimeters, so we can remove the microorganism. After that, we do good irrigation, good shaping, good activation to irrigant, trying to reach all the species that bacteria already present. All these steps just to remove the infection. And after provide a good cleaning, we do obturation. Why? To prevent reinfection. So still our focus is in the microorganism. So it is not about having good looking radiographs. We're not treating radiographs, we're treating patient. So we should be knowing the aim of our treatment. If you know that you're fighting with microorganisms, for sure, you will take your time trying to look for extra anatomy. You'll take your time trying to reach to the four working lengths by passing and manage separate instruments to reach to the working lengths to provide a good cleaning. You'll do activation to the irrigant because you understand that already anatomy is complex. This is the main goal of our treatment. Okay, for that case, we need to manage now Gutta-percha removal, and actually it was easy to remove because it is single cone. After that, we need to adapt our apical plugs or MTA or putty material to the apical third of the canal, just to provide the seal, because here we can't seal using Gutta-percha. In that cases, we need MTA or putty bioceramic, maybe pyodentine, to adapt better to the apical region and provide a good seal to our cavity. Still, we have another challenge, is the cleaning. In that cases, we're not doing shaping, right? To which size of file we should reach in this canal? We can't say that. We need to do chemical disinfection. We rely more in chemical disinfection in these cases rather than shaping. Actually, files are of limited benefit in that case. Maybe you can do minimal mechanical debridement, but the main rule or the main agent we're using against microorganisms is irrigation and disinfection, and for sure, the activation to irrigant. Now I'll show you how we can manage this kind of apical plugs or to seal it with this kind or with this good quality, what we can use, because I know many have the challenge of when they put MTA or Gutta-percha or putty bioceramic, it will go all beyond the apex. Actually, you don't have big problem taking the material beyond the apex, but the big problem is the seal. We want to provide the adaptation of the material to the irregularities at the apex. So same way for single cones, we can remove using micro tweezer or micro forceps. So we'll avoid cutting if we're using rotary instruments. And as I will place MTA or patchy ceramic in that case, I preferred not to finish the treatment in single visit because already this treatment long time ago, so the area now full of bacteria and microorganisms, and that medium is not good for our repair material, for MTA or patchy ceramic. So I want to change the pH. That's why I use calcium hydroxide as intracanal medication for 2 weeks. Then they call the patient. Now I have good environment, or then that media is ready to receive our repair material like MTA or patchy ceramic. Now we'll see how we apply. How we did first the cleaning. In the second session, I need to remove the calcium hydroxide. I prefer to use the water-based calcium hydroxide, so it would be easy to be removed, not the oil-based one. Oil-based one, quite difficult to remove. So now it's saline and removing. Again, dynamic files. So that files on high speed will adapt to irregularities, trying to touch more the wall or more the anatomy. This is just to remove all remnant of the calcium hydroxide, also to do minimal mechanical debridement to the walls, followed by ultrasonic activation to the irrigant, ultrasonic activation to sodium hypochlorite, and as it is a straight canal, so we can use ultrasonic activation for the whole canal. Actually, in regular cases, or when we have curved canals, we can't use ultrasonic activation to the whole canal. It should be only limited to the straighter portion of the canal. But here, all the canal is straight, so it is safe to use ultrasonic activation. Still, my focus on my enemy, the microorganism. Give time for cleaning and disinfection. This is micro aspirator, doing drying to the canal and try to suck what might be present inside the canal using micro aspirator or micro suction tip. Here, I will place a collagen matrix or collagen sponge. A sponge which we need to push beyond the apex or below the margins, so it will act as a matrix. So when you place your MTA or patchy ceramic, you will have good adaptation as the apex, and you don't have that over extrusion of the material. Now I placed the resorbable matrix. Actually, within 2-3 weeks to resorb. Same for the second canal. Now I'm applying my patchy ceramic material, the root apical filling. I'm doing adaptation to the material using a micro brush, and yes, we're calling it adaptation, not compaction. For the material like MTA or ceramic, we'll call it adaptation or adapting the material. Now we can see how material is well adapted to the apical portion. I placed wet cotton with temporary filling and called the patient for next visit. Now I confirm that the patchy ceramic already set. The material sets well. I need to do backfilling using warm Gutta-percha, so I'm just putting a little bit of ceramic sealer on the wall, so it will act as a guide to our Gutta-percha where to flow and give better adaptation to Gutta-percha or Gutta-percha on the walls. This is just for the mid portion of the canal, because actually for the coronal portion, we'll leave for post space, as a post space. Now, compaction of the Gutta-percha. This is what we are calling 3D seal, or adaptation of form Gutta-percha to root canal irregularities. Now I have good apical plug, good adaptation to material, and the rest of the canal is a post space. So now we saw how in literature it is very important to identify the reason for failure. We knew that prognosis is different for cases like perforations and cases like separated file. When you have an altered anatomy or unchanged anatomy, you still have a favorable prognosis. However, if canal anatomy changed, prognosis will be low or it will not be good. We manage apical plugs, we manage perforations, and we knew that locating the anatomy is very important, and also adapting our knowledge to the anatomy is very important, not adapting anatomy to your knowledge. This is the end of my presentation, I think. Yes. So I'd like to thank you